You wake up. Before you open your eyes, before you check the time, before you think about anything else, your mouth is already telling you something. It's dry, thick, almost like the inside of your lips have been sealed shut overnight. You reach for a glass of water on the nightstand, take a few sips, and within a minute, you've already filed it away under the same mental category you've been using for years. Just one of those things. Maybe you didn't drink enough yesterday. Maybe the air in the room is too dry. Maybe it's the season. Maybe it's just getting older. And then tomorrow morning, same thing. The morning after, same thing. Week after week, month after month. Here's what I need you to hear clearly. Waking up with a dry mouth every single morning is not just an inconvenience. And after 60, it is not something your body is doing at random. It is a signal. In many cases, it is one of the earliest and most consistent signals your body sends before a deeper problem makes itself known through other, harder to reverse ways. What concerns me as a physician is not the dryness itself. What concerns me is what it may be quietly pointing to, and how often people above 60 spend years living with that signal without anyone ever sitting down and explaining what it might mean. That is what I want to do with you today. I'm Dr. Rose. I've spent 12 years working closely with patients over 60, and one of the things I've learned in that time is that the body rarely shouts before it whispers. The signs that matter most are often the quiet ones, the ones people dismiss too quickly, the ones that get labeled as aging when they actually deserve a much closer look. This channel exists to help you understand those signals. If that kind of content matters to you, I'd like you to subscribe so you don't miss what we cover here. And if today's topic is something you've been experiencing or someone you love has mentioned, a like on this video helps more people find it who may genuinely need it. Let's get into this. Most people assume that dry mouth upon waking is just a hydration issue. You didn't drink enough water the day before, so your body ran low overnight. Simple explanation, easy fix. And in some cases, that's true. Mild dehydration is absolutely one cause of morning dryness, and we'll talk about that specifically. But here's where the picture starts to shift. After 60, saliva production naturally decreases. The salivary glands age just like every other structure in your body. They become less efficient. That means your baseline is already lower than it was at 40. Now take that reduced baseline and add any one of several conditions that interfere further with saliva production. And what you get is a persistent daily symptom that many people live with for years without understanding what it's actually reflecting. The problem isn't just the dryness. The problem is what the dryness may be quietly pointing to. A blood sugar issue, a sleep disorder, a medication interaction, an autoimmune response, a kidney signal, each one requiring a different conversation with your physician. And when all of those possibilities get collapsed into that's just age, years pass, without the right questions ever being asked, what I want you to walk away from today understanding is this. Dry mouth every morning is a symptom. Symptoms have causes, and causes, when found early, have options. Before we get into the specific causes, there's something worth understanding about saliva itself because most people underestimate what it actually does. Saliva is not just moisture in your mouth. It is an active protective fluid. It contains enzymes that begin digestion before food even reaches your stomach. It contains antimicrobial proteins that help prevent infection in the oral cavity. It contains minerals that protect tooth enamel. It lubricates the throat in ways that make swallowing safe and efficient. When saliva production drops, none of those functions disappear quietly. They degrade slowly in ways that show up as tooth decay that seems to come from nowhere, as gum inflammation that doesn't resolve, as difficulty swallowing dry foods, as an increased risk, particularly in older adults, of aspiration. That last one matters more than people realize. Aspiration pneumonia, caused in part by difficulty swallowing, is among the leading causes of hospitalization in people over 75. It rarely starts with drama. It starts with something like a dry mouth that made swallowing slightly harder than it used to be. Now add the age factor. After 60, the salivary glands genuinely produce less. This is not a theory. It is a documented physiological change. The World Health Organization recognizes that xerostomia, the clinical term for dry mouth, affects roughly 20 to 30% of the general population, but rises to more than 40% in adults over 65. In older adults taking 5 or more medications daily, which describes a significant portion of Americans in that age group, prevalence approaches 60%. That number is not a footnote. It means that in a room of 10 medicated adults over 65, 6 of them may have chronic dry mouth, and the majority believe it is just a normal part of getting older. It is not. It is a symptom sitting on top of a baseline that has already shifted, and that distinction matters enormously. The first cause I want to walk through is dehydration, but not the kind most people picture when they hear that word. When people think of dehydration, they think of extreme thirst, dark urine, dizziness, obvious symptoms. What I see far more often in patients over 60 is something quieter. A mild, chronic, low-grade dehydration that the person has no awareness of because the signal that should alert them has weakened. Here's why this happens. In the hypothalamus, there are structures called osmoreceptors. Their job is to detect when your body's fluid balance drops and trigger thirst. After 60, those receptors become progressively less sensitive. A young adult begins to feel thirst when they've lost roughly 1% of their body's water volume. An adult in their 70s may lose 3 or 4%, a meaningful deficit, and feel nothing. No thirst, no obvious signal, no internal alarm. The result is a state of chronic mild dehydration that the person cannot feel, does not correct, and often doesn't even know is happening. And one of the clearest external signs of this internal state is dry mouth upon waking, because during sleep, you lose fluid through respiration, and if you are already running low, the morning symptom becomes more pronounced. This means the first and most actionable step for anyone experiencing consistent morning dryness is intentional hydration. Not responding to thirst, but building hydration into the structure of the day before thirst arrives. A glass of water when you wake, one before each meal, one before bed. Not because that solves every cause, it doesn't, but because ruling out or correcting this baseline piece is where every honest investigation should start. Here is one that genuinely surprises most of my patients when I explain it. If you wake up with a dry mouth and a dry, slightly raw feeling in your throat, there a meaningful possibility that what happened during the night has less to do with fluid and more to do with how you were breathing. Sleep apnea, the repeated partial or full collapse of the upper airway during sleep, causes the body to compensate by breathing through the mouth. When the throat closes and airflow is restricted, the reflex is to open the mouth to maintain some passage of air. Spend several hours with your mouth open, and you will wake up with tissue that is noticeably dried out. The tongue, the inner cheeks, the soft palate. What makes this particularly significant after 60 is that the muscles of the throat naturally lose tone with age. The risk of obstructive sleep apnea increases substantially in older adults. Estimates suggest that more than half of adults over 65 have some degree of sleep-disordered breathing, and a significant portion have never been diagnosed. The reason they haven't been diagnosed is partly because sleep apnea has an image problem. People picture the classic presentation, a heavy snorer who wakes their partner every night, but many older adults with meaningful apnea snore minimally, or their partner has grown accustomed to it, or they sleep alone. The symptom they notice is not the nighttime breathing. They sleep through that. The symptom they notice is the dry mouth, the fatigue that doesn't match a full night's rest, the dull headaches some mornings, the frequent waking to urinate. Those are the questions I ask when brings me morning dryness. Not just are you snoring, but do you wake feeling rested? Do you have morning headaches? Are you up 2 or 3 times at night? When the answers come back the way they often do, a sleep study becomes the logical next step. And when the apnea is treated, the morning dryness is often one of the first things to resolve. This is the cause I take most seriously from a prevention standpoint because it carries the most weight in terms of what it may mean for long-term health if it goes unaddressed. Dry mouth is one of the earliest signs of elevated blood glucose, and in adults over 60, the relationship between these two facts often goes completely unrecognized. The mechanism is direct. When blood sugar rises beyond what the body can manage efficiently, the kidneys attempt to filter and eliminate that excess through urine. That process requires significant amounts of water. Water the body pulls from its own tissues. The result is internal dehydration at the cellular level. Salivary glands, which require proper fluid balance to function, produce less, and the person wakes up with a mouth that feels wrong in a way they cannot quite explain. What makes this especially important in the over 60 population is that type 2 diabetes frequently presents differently in older adults than in younger ones. The classic symptoms, intense thirst, dramatic weight loss, obvious fatigue, are often muted or absent. Instead, what clinicians see is something quieter: dry mouth that won't resolve with water, mild fatigue that blends into the background, slightly more frequent urination that gets attributed to the bladder or the prostate. The CDC estimates that more than a third of American adults over 65 have diabetes, and that nearly a quarter of those cases are undiagnosed. That is not a small number. It means millions of people with a condition that has available, effective management options are currently living without that information. If morning dryness is your primary symptom and it coexists with thirst that doesn't fully resolve through the day, with fatigue that doesn't match your activity level, or with increased nighttime urination, a fasting glucose test and a hemoglobin A1C are the most straightforward next steps you can take. Both are standard blood tests, both are covered, and either one could give you a piece of information that changes the trajectory of your health. This is the most common cause I encounter in clinical practice, and it is the one that receives the least explanation. The U.S. Department of Health and Human Services has documented more than 400 medications that list dry mouth as a known side effect. 400. And many of the most common ones are precisely the medications that adults over 60 take with the highest frequency. Diuretics for blood pressure, which reduce total fluid in the body. Antidepressants and anti-anxiety medications, which affect the nervous system pathways that control salivary glands. Antihistamines for allergies, bladder medications, sleep aids, Parkinson's. Medications. Each of these on its own may produce only a mild reduction in saliva. Manageable. Not particularly noticeable, but here is what changes the picture dramatically after 60. The concept is called polypharmacy, the simultaneous use of multiple medications. In adults over 65, taking 5 or more medications at once is common. It is often medically appropriate. But the cumulative effect on salivary function is something that very few people, and frankly fewer physicians than should, sit down and explicitly map out. When you are taking a diuretic, an antidepressant, an antihistamine, and a bladder medication at the same time, the individual effects on saliva are no longer individual. They compound. The result is a mouth that has become chronically, significantly dry. Not because of any single prescription choice, but because nobody has looked at the list as a whole with this specific outcome in mind. The single most useful thing I can tell you here is this: gather every medication you take, prescription, over-the-counter, supplement, herbal, and bring them to your next appointment. Then ask one direct question: could any of these be contributing to my dry mouth? And is there an alternative that might have less of that effect? That question alone, asked clearly and directly, has meaningfully changed the daily experience of quality of life for many of my patients. You do not necessarily need to stop any essential medication. You may simply need someone to look at the whole picture at once. There is a condition I want to name specifically, particularly for women reading this, because it affects more people than most realize. It takes an average of 3 to 5 years to diagnose, and dry mouth is often its most persistent and early symptom. Sjogren's syndrome is an autoimmune condition in which the immune system mistakenly attacks the glands that produce moisture, primarily the salivary glands and the tear glands. The result is a dry mouth that does not respond to water the way dehydration would. Drinking more simply doesn't fix it. The glands themselves are being compromised from within, and no amount of fluid intake fully compensates for reduced secretion at the source. Approximately 90% of people diagnosed with Sjogren's are women, and diagnosis is most common in the 45 to 65 age range, precisely the period when many women attribute changes in moisture and fatigue to menopause, understandably and not unreasonably. What gets lost in that attribution is the autoimmune process running underneath it. The reason this takes so long to diagnose is not that the symptoms are rare, it's that they look like other things. Dry mouth looks like dehydration. Dry eyes look like fatigue or screen exposure. Joint aches get attributed to age. Fatigue blends into the background. And so the condition progresses without a name for years, during which time targeted treatment that could significantly improve function and comfort is not being received. If you are a woman who wakes with persistent dry mouth that doesn't respond normally to hydration, and you also notice that your eyes feel dry, gritty, or uncomfortable, particularly in the mornings or in dry environments, and you experience fatigue and joint discomfort that don't have a clear explanation, that combination deserves specific attention. There are blood tests that look for the antibodies associated with Sjogren's. They exist precisely, so this doesn't have to take 5 years. The sixth and final cause I want to walk through is one I discussed in depth in our first channel video, and it has particular relevance here. When the kidneys lose filtering efficiency over time, which is a gradual, largely silent process, the body attempts to compensate by excreting more waste through increased urination. That process pulls fluid from the body's tissues, including from the glands that produce saliva. The result is a dryness that often comes with a distinctive and important clue: a metallic or unusual taste in the mouth. Not just dryness alone. That metallic quality is not random. It reflects waste products that healthy kidneys would have cleared, reaching the saliva because they were not fully eliminated through normal filtration. It is one of the body's few visible signals of a problem that otherwise operates entirely below the surface. Chronic kidney disease affects roughly 1 in 3 adults over 65 in the United States. The vast majority have no idea because in early and moderate stages, there are almost no symptoms. The kidneys compensate quietly until they cannot, and by the time symptoms appear in the conventional sense, the disease is often already at a stage where the options have narrowed significantly. What changes the outcome is finding it early. And one of the most important things I can tell you about kidney function testing is this: creatinine alone is not enough. Creatinine can appear normal even when kidney function has dropped to half its capacity. What you need is the eGFR, the estimated glomerular filtration rate, which gives a much more accurate picture of how efficiently your kidneys are actually filtering. If morning dryness is your symptom, and particularly if it comes with leg swelling, foamy urine, blood pressure that has become harder to control, or persistent fatigue, asking specifically for the eGFR is one of the most worthwhile requests you can make at your next visit. Here is what I want you to carry forward from today. The body doesn't produce symptoms for no reason. It doesn't create discomfort arbitrarily. When something changes, when a symptom that wasn't there before starts showing up consistently, it is attempting to communicate something. The question is not whether to take that communication seriously. The question is whether we are willing to actually listen. Dry mouth upon waking every morning is not a quirk. It is not an inconvenience you owe it to yourself to simply tolerate. It is information. It may be telling you something about your hydration, your sleep, your blood sugar, your medications, your immune system, or your kidneys. And each of those possibilities carries a very different set of implications and a different set of options. The people who preserve the most function and independence after 60 are rarely the ones who got lucky. They are the ones who caught things early, who asked the question before the situation required urgent answers, who recognized that a quiet signal deserved a clear-eyed look rather